Perfect. Okay, I've got confirmation that everything seems to be working, so I think we're just about on time. So we'll get going. So, hi, I'm Ralph Lloyd-Edwards, and I'm going to be taking you through this evening's webinar. Before we get going, I'm going to take a few moments to tell you a little bit about VET.CT and how our radiology service can help you, your teams, and your patients. VET.CT is a global company of over 150 radiologists, and we're here to help you, whether you're in first opinion practice, university, specialist hospitals, or another clinical setting. Our team of radiologists provide expert interpretations on a range of imaging modalities, from X-ray through CT, MRI, fluoroscopy, and nuclear med, across a full spectrum of species. What sets us apart is the quality of the reports. Not only do we spend quite a lot of time annotating images, so you can see areas of concern. We also ensure the reports you receive contain clinically relevant differentials and comments so that all of our reports are backed by a unique clinical warranty. So you can trust the information in them and proceed with the next steps for your patients with confidence. Not only this, but we have an incredible support team who are all clinically trained and are available 24/7. You can ask them for help or support anytime, and you can also communicate directly with our team of radiologists if you have any questions about your case. So if you'd like to see the VET.CT difference for yourself, you can scan the QR code on screen to view some example reports. You can also reach out to our client success team to find out more and set up a no obligation discovery call at your convenience. Okay, a little bit of housekeeping before I'll get into the presentation proper. It is being recorded. It's being recorded already, so just please be aware of that. This is so you can share, replay it, and share with any colleagues of kind of interest. Talk's going to be about 30 minutes long, and then we're going to go into a Q&A period. So please drop any questions you have. So I'm Dr. Ralph Lloyd-Edwards. I'm a radiologist at VET.CT. I'm also one of the senior leads in the education department, and I've literally just recently completed a PhD, which I actually forgot to add this time. The use of CT is really growing across particularly cats and dogs. We get a lot of questions about it and its applications, so that's really where tonight's talk is going to focus. So going into the talk itself, why are we presenting these sessions? We're going to try and help. We're going to try and apply the concepts already covered in technical lectures to illustrate the key advantages of CT and when it might be appropriate for your patient. We're going to kind of break these down into key questions. So why choose CT? What information could CT provide? When may CT be indicated? And how could CT influence patient outcomes? There are going to be 4 sessions, each one 30 minutes long, following QA. And there's going to be a range of cases, all chosen to illustrate a particular strength in an indication, or to prove a particular point, or maybe not prove, but at least start a particular conversation. Interactions are welcomed and encouraged, so please don't hesitate to drop your questions in. Learning objectives here is to demonstrate the key strengths of CT and why it's a fantastic imaging modality. So this is where I spent most of the time last time. The last session, for anybody who hasn't seen it, please feel welcome to review. It's up for review now. It was concentrating on the head. So we tried to stick to one body region and just show what CT could do particularly well and what its kind of strengths were. This time, we're going to move more on to this second bullet point. So how to differentiate how it varies from other imaging modalities. So I've tried to include a number of comparisons. And finally, to explore how CT can change patient outcomes and help your patients. Okay, so we're going to run through the cases. Just a little bit of a warning going into them. I'm expecting this first case to take quite a long time. They're not going to be equally weighted. So if this one takes half the time you're expecting, please don't be alarmed. I'm kind of expecting that, and then it should speed up and make up the time towards the end. Okay, so this first case is a 6-year-old female entire pointer with a history of suspected pyothorax diagnosed at ultrasound. These were radiographs, which we had submitted first of all. So we had a full set of left lateral, right lateral, and a dorsal ventral radiograph. So looking at these, I think the first kind of key thing to keep in mind, or the first key observation, was basically there's an increase in opacity. There's an increase in soft tissue or fluid opacity throughout the majority of the thorax, particularly this ventral aspect in the left lateral view, this kind of area here. And there's also this increase, particularly in the left hemithorax and the dorsal ventral. Secondary to that, you can see the lung lobes are retracted in towards the hilus. So this is kind of lung parenchyma, and where it should normally be filling the entire thorax, you can see these edges of the lung lobes are really pulling away from the ventral thorax and coming in towards that hilus, towards the tracheal bifurcation, kind of pulling in centrally. And there's also these pleural fissure lines. So between the lung lobes, you can see this fluid opacity dividing the kind of right cranial from right middle to right caudal, the different lung lobes. So all of this kind of adds together to mean there's a degree of pleural effusion. So that fits. We were told suspected pyothorax. This very, very much fits with a pleural effusion. Other findings, we've got this irregular area of increase in opacity in the caudal dorsal thorax. So you see here, it almost looks triangular, and exactly the same in the left caudal thorax on this side. I'll just flick onto the next slide to make it a little bit more evident. I've just put a ring around this area of concern. So it's a little bit odd because this area of increased opacity is conserved across views, which if it was just fluid kind of slushing around and going where it wants, that may not be the case. So we're maybe question marking that region. I think another possible concern here is this mediastinum is really quite wide. So the two lungs are spread apart, but of course, this is radiography. So we have the 5 basic opacities of kind of gas going through fat, soft tissue and fluid, which are exactly the same opacity, so can't be differentiated, and then onto mineral and finally metal. So we know there's a widened mediastinal. Why it's widened, whether it's soft tissue, whether it's just fluid, very unclear. And finally, which I should have mentioned, is there's also some pulmonary changes. So these are not perfect lung lobes. There's a little bit of an increase in opacity and a decrease in visibility of the pulmonary vasculature. So the summary here, kind of these findings. And I suppose the next question is, what next? What do we still need to know? The radiographs have told us with certainty that there's pleural effusion. However, there's the remaining lesions are kind of suspected. We've outlined this area in the caudal dorsal thorax, but we don't know what it is. We don't know exactly in which compartment or where it is. We can make suggestions, but we're not sure. We also, so it's more trying to confirm if there are additional lesions, if there's something going on in that cranial mediastinum, and also trying to confirm its position, pulmonary, pleural, mediastinal. So what we know, what do we need to know is to confirm the lesions, confirm the locations, and also assess those lung lobes. If there is a pleural pathology, there could also be something in the pulmonary. So we're trying to find out a little bit more. And unsurprisingly for a CT talk, we're going to do that with CT. So for anybody who was with us last time, this might be kind of more familiar, just a different body area. But for all of these cases, I'm going to try and use a standard orientation to make it a little bit easier to follow the images. So what we've got here is a transverse slice, kind of cutting straight through the patient with the right-hand side on the left of the image and left-hand side on the right of the image. Dorsal's up here, ventral here. And then on this right-hand side of the screen, I've got a sagittal view. So this is almost as if you've taken a lateral radiograph. This is a similar view, just a single slice through. And this purple line represents where we are on the transverse view. So I'm going through this. This is the spinal cord, this little soft tissue area here. These are the vertebrae, the kind of bony area around it. And it's important to note, this is a soft tissue series. So what that means is we're using a really narrow little window. Manuel talked about these in his talk. So basically, rather than looking at the huge range of different densities available, we're narrowing in. And we're just trying to look at that very specific differences between fluid and between soft tissue. Because of that, areas like the lung, so all of this kind of black stuff, you can't tell the gas from around the patient from the lung. It's all kind of looks the same. And these bones, you can't see much about them. They just all look white. But that's almost by intention in this series. We're cutting out anything outside of a certain range and just focusing in on what we want to see, which is that soft tissue fluid in as high a detail as possible. Also in this series, we're using contrast. So to save on time, I haven't shown the pre-contrast series. So you can see this is the heart, and these are the various great vessels chambers, and this is the myocardium surrounding it. So because there's contrast within the vessels, those heart chambers are showing up as being very, very dense. So going on through here, vertebrae, sternum, ribs around the outside, coming on through the heart here. This is for various musculature, scapula. Importantly here, these are chest drains coming into each side of the thorax, and then caudal vena cava, and finally the liver, and now we're going into the stomach and the abdomen. So after seeing that, I suppose the next question is, let's have a look for some abnormalities. We've got these chest strains, we've got lungs, which these should normally occupy the majority of the hemithorax. And instead of that, you've got lung, and then you've got this ventral region of kind of homogeneous soft tissue or fluid opacity content. So this kind of dark gray area is basically all of the fluid. And you can imagine the lungs are floating up because they're gas filled, the fluid's sitting down and really surrounding them. So we were right, in essence. There's fluid in the chest. There's a pleural effusion. I think what's interesting in this is how much more we can see. So, for example, this is a lung lobe coming down, and this area here is basically, this is a bronchus, and this is a collapsed section of lung. So it's rather the lung has basically got no air in it, it's been pressured out by that fluid, so it's just collapsed and an atelected kind of a lung. And you can see this whole section here with a central bronchus and then surrounding collapsed lung. You can see little bits of fat. So this is fat floating around the pericardium. And what's kind of more, the major finding I would kind of highlight here within this fluid is, rather than, if you remember on radiography, we just said fluid, soft tissue opacity, and that was kind of it. Here, you see that's really kind of, it's underselling what's going on here a little bit. Not only have you got this dark gray fluid, you've got this kind of irregular, proliferative, soft tissue attenuation material really spreading throughout the entire pleural cavity. So all of this is abnormal tissue. It's horrible kind of proliferative areas of the pleural or kind of material within it. You can also see these little cavitary areas. So not only has it got this horrible kind of proliferative pleura, it's also trapping in areas of fluid within it. So this really fits with an established pyothorax, which was our kind of original suspicion. So we've confirmed the fact there's a lot more going on. I think the next thing is to try and look at a few more of those findings that we saw at radiography and see what we can see. So here, this is the esophagus, and this is that area which we said were a little bit consistent just to be fluid. So a lesion within the left caudal lung lobe. And you can see there really is kind of a focal lesion there. We can have a look at the cranial mediastinum, and you can see there's quite a lot of proliferative soft tissue, so very similar tissue to what we were looking at in the caudal pleural cavity. So this is more consistent with just proliferative pleura than kind of anything else. And finally, there's even more things we just didn't see on radiography. So if you look at this area here, this is lung. This is irregular soft tissue, and then this area in the middle is a big area of trapped gas. So basically there's an abscess, there's a cavitary lesion there. So an area of loculated fluid or gas. You can also see all of these pleural changes are not just restricted to the ventral aspect. See this irregular kind of proliferation of the dorsal aspect as well. So we've gone a lot further than radiography with this. We've kind of said not just are these changes, this is exactly what's happening where. We can look at the position of the chest drains and say, okay, that might be why it's working on what it's not. We could go on to scan the abdomen if that's indicated, and we've got all of these findings. So we've got, as we've talked about, this proliferative pleura, free fluid marked with yellow arrows, and then a few focal lesions of concern as well. That was the soft tissue. So that was just the soft tissue aspects of the case. But what's important with CT is we can use different windows, we can use different series. So not only have we got the soft tissue, this is a pulmonary series. So this is basically a much sharper looking series to pick up finer details. And it's also windowed in. So if you remember what this looked like previously, when you just had black around the patient, black in here, and now you can really see what's free gas. This patient had a little bit of gas coming in with the chest drains. What's free gas and what are the lung lobes itself? So you've got a lot more detail about what's going on. And you can see looking throughout there are a few interesting findings. First of all, the lungs are collapsed, which is what we suspected. You can see those folded margins, the fact they're increased in, they're much denser than they should be. Again, irregular collapse of lung lobes. It's just folding around the margin, total collapse here. You can also see there's some areas. This side is kind of dependent. It's just sitting on top of the fluid. And you see on this side, this caudal aspect is almost pinned to the interior of the thorax. So we've got a strong suspicion of an adhesion formation or something here, really keeping that there. So again, we can screen for any kind of big focal pulmonary lesions. We can look at how the lungs are doing, and we can assess, rule in, rule out different pathology. So these are just a few of the areas we've kind of talked about in the previous slide. So the summary of the CT is we are looking at pyothorax with multiple associated findings and loculated regions. So what did CT tell us radiography didn't? Well, essentially, we got a very similar diagnosis. We knew this was a pyothorax. We can now classify it. We can see where that pleural proliferation is. We can assess best routes of drainage. We can give a lot more information. We can confirm lesions as being present or absent and give a good screening or a relatively good screening of the lung. We can say what's happening in that mediastinal region and also look at the pulmonary changes which are present and look, are they more likely atelectasis or have we got a pneumonia going on here as well? So what did CT tell us? It gave us more precise findings. It gave us differentiation of fluid and soft tissue, and it also allowed us to localize the findings, and it just eliminated superimposition. The problem with a lot of, radiography is great at the thorax generally, but if you have multiple changes superimposed over each other, it can become quite challenging, and that's one of the key advantages of CT. How has it impacted the patient? Well, the diagnosis is known, but the additional value is basically in the further characterization. So we can give better prognosis, informed decision making, do any additional measures need to be taken, and key management points. Could this have been achieved in a different way? Repeat radiography after drainage would have given more information about the condition of the lungs. So that may have already given quite a lot. And ultrasound can also give more information about the pleura and the periphery of the lungs. But of course, ultrasound might be obstructed by lung lobes or by gas or so by something in the way. So it's a fantastic modality and could have told a lot, but may not have given us everything. But this case was not shown really because CT is the only answer. This was more chosen, to show the comparison and the additional value that can be given. So key points: it allows assessment without superimposition. Differentiation of soft tissue and fluid. So you're not limited to those 5 basic radiopacities. You've now got thousands of different attenuation values, and you've also got precise localization of findings. But it is not always the only approach. The idea here is not to say every case needs CT. It's to say it's a really valuable tool in the right instances. So case 2. This one is another interesting comparison. It's a 3-year-old female entire Shetland sheepdog. It's got an acute lameness of the right hind and metatarsal swelling. Having a little bit of a look at the radiographs, not too much on the stifle, and the first thing that caught my eye was basically this soft tissue swelling surrounding the tuber calcaneus. And if we zoom in a little bit further, you see just at the area where the tendon's inserting, there's this very focal soft tissue swelling. There's also osseous structures over the caudal aspect, caudal distal aspect of the calcaneus, and this slight soft tissue swelling, which was also what they were kind of seeing clinically. So we've got soft tissue swellings, some osseous structures, and a conclusion with that, we've got a suspected soft tissue injury of the right plantar tarsal region and a possible esophageopathy, fragmentation of that plantar tarsus. So what next? We've got a region of abnormality, but we haven't got a clear diagnosis. So the next steps: clinical correlation, ultrasonography, or CT are all kind of options. Again, I chose this case for comparison's sake. Not every lameness needs to go to CT. And in this case, when you have soft tissue changes, ultrasonography would have been a very valid choice. I think the limitation of ultrasonography is partly, having the optimal experience, having the optimal equipment. to make it suitable in every case. I think the thing to keep in mind with CT and musculoskeletal, particularly in this distal limb, is CT has a very good spatial resolution, but it's not infinite. So, and it also has a good soft tissue contrast resolution, but again, not perfect. So particularly in very small patients, you may not have much luck in differentiating very small, very subtle soft tissue structures or ligaments. That's not what it's good at. You know, ultrasound can do that very, very well, but CT could be thought about in this case. Partly exclusion, you know, it can look at all the bony structures and maybe remove findings as well as, or remove possibilities as well as add them. And partly it does give some soft tissue information. So to give an idea here, this is in bone algorithm. This is basically scanning through the tarsus. You've got the tibia, fibula, this is the caudal aspect of the limb, so around the common calcaneal tendon, and then the cranial aspect of the limb here. Exactly the same as last time. The purple area is the scan plane. Already going through this area just proximal to the tuber calcanea, you can see a bit of a soft tissue swelling. Going further distal, you're seeing, although it's in cross section, you see this little osseous structure we were noting previously. And also as we're going through the tarsus, we can look for any other osseous abnormalities, anything which might be wrong, anything which might be to blame for the clinical signs. And in this case, we've really got the whole way down to the toes included to rule out. Okay, so what do we see? Also on that, already we've got a slightly better classification of the findings. So we could see this on radiography. We basically now see it in 3E. So we can see this small little fragment from physiophyte. I think the key finding here is you've got surrounding new bone formation. So this is not like this is an acute onset lameness, and we don't see a well-defined fracture line. We've got a very irregular surface. We've got evidence of modeling. So this is at least in part more a chronic kind of process. So that's the main bony finding. Next, we're going in through the soft tissue. Now, this is where I said this can be, depending on size of patient, quality of machine, contrast versus not, this can be a little bit challenging. And you can see, although you can see tendons in various parts, then you know, it takes a little bit of picking out, and particularly if you've also got soft tissue swelling surrounding it, it can be challenging. So looking on through here, I think we can check the area around that fragment and see there's not a huge amount of soft tissue swelling there. You can see the slight prominence and accumulation there, and also the really big marked finding is further proximal. So this really marked swelling surrounding the proximal aspect of the tuber calcaneus. And having given all these caveats and said CT, you know, is giving fine detail on things in the distal limb, it can be challenging. This case I really liked because it was excellent. This is basically the common calcaneal tendon. And then what's interesting in this case is this structure coming towards the lateral side is actually the superficial digital flexor. So rather than sitting exactly where it should do over the back of the calcaneus, basically it's kind of deviated off. And I think what was really, I started to suspect this in the transverse plane, but what really I thought was more convincing, and what a lovely aspect of CT is, you've got the option of this 3D reconstruction. So rather than having, rather than just being sticking to kind of cross sections, 3D can sometimes give a really nice overview of findings. It can give a good kind of sum of the parts and allow you to see everything. And you can see here how you got this really nice, well-defined soft tissues over the caudal left limb, and then on the right limb, how you've got this injury that's kind of come loose and come over, so on this, we can diagnose this lateral luxation of the right superficial digital flexor tendon and associated or suspected lateral luxation and associated soft tissue swelling. There's an physiopathy and fragmentation of the distal calcaneus, and there's also some regional swelling and some osseous structures over the tarsus. So the luxation for position of the tendon and associated swelling, could this be the cause of lameness? Yeah, it could. This fits with an acute style of lameness, and I think there was all, and it could fit with the kind of findings. Calcaneal changes is the distal kind of osseous changes, more unknown relevance. I think the fact there's new bone formation suggests a pre-existing condition. Acute on chronic injury is always possible, but the fact there aren't that many soft tissues changes, I would be less convinced this would be the primary issue, at least. So how does it impact the patient? We have a diagnosis that allows appropriate management and prognosis. We've got additional findings of kind of unknown importance, and we've got really good examination of the osseous structures without any superimposition to basically allow rule outs as well, to try and check for any acute fractures occurring there. Could the outcome have been achieved in a different way? Well, high frequency ultrasonography or MRI could have also given more soft tissue information. And again, I think ultrasonography, particularly when you're thinking about tendinous ligamentous injuries, can or would sometimes be my first choice. But of course, that's got quite a specific use for soft tissues, and it also relies on operator equipment, whereas CT can often give you a little bit of information about a few things. So key points. CT allows the objective comparison of structures, an overview of multiple regions and tissues. Rule outs, so excluding big fractures of the tarsal bones, as valuable as rule ins. CT may not be the only way to make a diagnosis. That position of the tendon, CT was not the only answer. And establishing relevance for finding is not always straightforward. So trying to work out how involved otherwise the distal calcaneus was. Just out of interest, it was the first case I'd seen. I thought I'd put in a nice paper. Okay, final case. So this one isn't a comparison, just in the interest of time, but I thought for the final one, I'd pick a suspected portosystemic shunt. So the rationale behind this is basically it's something CT does very, very well. So I thought on looking at kind of Olga on my own case list, it was one worth highlighting. So this is the CT of the patient, and this is kind of exactly the same orientation as the last one. We're taking off where we left off. So now we're starting the caudal thorax, and we're going through the abdomen. So this is the liver, stomach, spleen, duodenum, pancreas, aorta, in the dorsal abdomen here. You can start to see intestines, intestinal content coming through. 1, 2, big kidneys, a little bit of free fluid down here in the ventral abdomen between, so you can see rather than being this kind of black fat, you've got gray free fluid filling in. And then finally, we've got to the urinary bladder. So that's kind of some of you may have already spotted. I try and do any interpretation in a fairly logical and structured fashion, but this was a very difficult case not to spot diagnose, because even at this level, I think if you look through this, you've got a big aorta and you've got a huge vessel over the right dorsal aspect of it. So even based on this view, I've got a suspected diagnosis. This looks a lot like a big distended azygous vein. So this kind of points us in the direction of a possible azygous shunt. And sure enough, if you follow it back, and it is quite a long way back, and keep your eyes on that vessel, you can see at that level, you've got a big chunky mesenteric vessel inserting straight into a big distended azygous vein. So, maybe we could have done that at ultrasound. It seems so far so kind of straightforward, I think. But then what was interesting with this case is a couple of aspects. First of all, if you ever look at this slice, or maybe one of these, it's trying to spot what's missing. This is aorta, this is right azygous vein, this is the esophagus, but there's no caudal vena cava. There's no overt caudal vena cava at this level. And actually, if we follow it on caudally, we can see there's really not a caudal vena cava throughout the cranial abdomen. And it's not until you get back towards after the insertion of the shunt and back towards the renal vessels, that then you see this vessel start to look more like a normal caudal vena cava. So what's actually happening here is the caudal vena cava is deviating kind of dorsally into that right azygous, along with all of the shunting vessels. So what you've got is a segmental aplasia of the caudal vena cava. In addition to that, if you follow I can't run this backwards, so I think it might be a case of take my word for it, but if you follow the splenic vein and all of the kind of components of the portal vasculature actually cranial and away from the location where it inserts into that very distended azygous, it's very difficult to make out a portal vein. So in a lot of shunts, you can still see the portal vasculature, it just reduces in size. So this is actually quite, it's quite an involved case. And trying to correlate all of those findings and, make sense of them, you could imagine could be quite challenging with an ultrasound probe. Whereas I really, I enjoy looking at shunts with ultrasound. It can be fantastic. It can be brilliant in a lot of cases, but it can also be very, very challenging. And I think an advantage in particularly complicated cases like this is not only do you get to look through the entire thing in these beautiful kind of cross sections and have objective information, you can also play with the information. You have lots of ways of trying to make more of it. So this is where I've kind of averaged and projected out the vessels to make it to kind of clarify the position. So this is normal caudal vena cava, and suddenly, zoop, and it goes upwards into the azygous vein. And these are basically the shunt inserting into the azygous vein. Not only that, so you can play with different projections, you can look at it in different angles, you can use different systems to try and make things more overt. You can also use 3D. This is, again, portal vasculature going straight into that abnormal azygous vein, and then this fails to one side. So it can give you a lot of ways and means with kind of experienced observer to try and get a lot of information out of it, and also to be able to clearly and concisely, communicate that information and give a very kind of visual representation of what a surgeon or what you're looking at with this case. So the summary of findings here is segmental aplasia of the caudal vena cava, an extrahepatic portal systemic shunt, and portal vein hyperplasia, along with expected secondary findings and many, many additional findings, which I kind of won't spend time going through. So what did CT tell us? It told us the shunt is present, and it allowed characterization of that shunt. It highlighted multiple additional vascular abnormalities were present, and it allowed assessment of secondary changes and several findings of unknown clinical importance. So you kind of screened the entire abdomen as well as looking at your primary findings. How does it impact the patient? Well, it gives us a diagnosis. We have a good diagnosis here. We know roughly what's going on. We know where things are inserting, so we can allow informed decision making in regards to management prognosis, and it highlights additional changes which might cause clinical signs in the future. Could the outcome have been achieved in a different way? Definitely. Ultrasonography can be great at assessing shunts. I think the key advantages of CT are a removal of the kind of operator dependency, removal of patient dependency. What you see in a very small kitten might be very different to what you see in a very large breed dog. It also allows very clear presentation of what you're looking at, which can be very helpful in respect to surgical planning. Key points. CT with intravenous contrast is a fantastic in assessment of vascular abnormalities, and also CT can give a great 3D visual representation of complex anatomical structures. And that's where I think playing with, or I shouldn't call it playing, but using your experienced interpretation to assess that data that CT gives you in multiple different ways to be able to get to the diagnosis can be very, very helpful. There's a little bit of a reference here about that segmental aplasia of the caudal vena cava. And finally, to round up, these are the kind of take-homes from this session, but CT can give a range of information over multiple body areas and types of tissue. So last time, I tried to stick to the head and just kind of show its uses there. Whereas this time, we've done lameness, done chest, done abdomen. So it's a modality which can be used in a lot of ways. CT is tomographic, so it often gives additional information with in respect to radiography. If you think about the information we got from radiography based on the lameness case or based on the pyothorax, and the additional input that CT could give us. Contrast media can be of key importance, so whether that's for vascular cases or neoplasia, etc. We looked at margination of the mass last time, and contrast media being really important in that. And finally, a big important caveat, the CT should be used to give maximum patient impact. It's not always indicated. And again, these cases were chosen to show comparison. Um, it's not to say that CT is right in every case. It can sometimes be a very interesting academic exercise, but it ought to be used when there's a very kind of clear clinical question, and you hope CT gives you a very clear clinical answer to then impact on that patient welfare. Perfect. So thank you very, very much for your attention. And we'll go on to questions if that's okay. So I'll just have a look through. And okay, so first question. So we're looking at so this is in relation to the first case, should pleural drainage be performed before or after CT? So, well, it can be performed both. I think the advantage of draining the pleura beforehand is exactly the same as radiography. Basically, if you remove that kind of compressive pressure on the lungs, then hopefully they inflate, and then basically the more inflated the lungs are, the more likely you are to be able to have a thorough examination, really see what's going on. Okay, so next question, and kind of related, is how do you remove atelectasis for radiographs and CT? So that's if, as in a case of pleural effusion or similar, if the lungs are collapsed, how do you then remove that atelectasis? Well, I think as discussed in the right answer, first of all, take away a cause or something compressing from them. If it's a case where you're just looking at positional atelectasis, it can be really, really, really challenging to remove. And I'm sure a lot of you very familiar with this at radiography, but once it's established, it can take a long time to get rid of. So my basic advice is if a patient comes in for CT, then if it can remain in sternal recumbency for as long as possible, that's fantastic. Sometimes we get problems if animals have been, say, in lateral recumbency for a long time because of something to do with the anesthesia or similar, then you can really get collapse, and it can be very, very difficult to remove, and that can kind of impact both radiographic and CT interpretation. Okay, so the next question is, okay, so a few now relating to body areas. So can you CT the entire hind limb of a lame dog or just one joint? So I think this first of all comes back to my kind of earlier comment. Generally speaking, the better the question, the better the answer. So if you've got a very clear clinical suspicion of what what the problem may be, and a kind of focused in idea, then that can give us far clearer guidance and allow really relevant kind of assessment. CT can be used, or sometimes, let me put it differently, CT is sometimes used as almost a screening tool to check multiple regions. It's possible, but it's not ideal. First of all, expense. You're paying for interpretation of lots of regions. Um, Secondly, really, the more information that's put in and the more we know, the more we can usefully feed back. But yeah, there are certain situations. I mean, a CT you can scan large areas. You can incorporate multiple joints, and particularly in areas without movement artifacts, it's possible, but it is a radiation-based modality. So as far as possible, it same as radiography, it should be targeted, and it should be due to a clear clinical question. Okay, so in that case, if there's a lame dog, should you scan both limbs or just the lame limb? Slightly contradicting what I've just said. I would normally prefer to have both limbs. I think the reason for that is, and I've stolen this quote from a colleague, Lucy Meehan, but I think it's a great quote, is imaging is a big game of spot the difference. If you have both limbs, you're far more able to make comparisons, to differentiate what might be normal variation for that patient versus what might be pathological. And also things like elbows, quite often you have bilateral pathologies. So if we can have a comparison, I personally find that most useful. Perfect. So I think, yeah, can I scan the entire patient? So, well, yes, you could, but I think this moves back onto the previous answer really about doing the whole limb or not. Ideally, you've got a strong clinical suspicion or you have a clinical question and CT answers that. There are instances when we end up when we'll interpret a large area of a patient. So, complicated lamenesses sometimes if metastasis, things like if you've got multifocal neoplasia or something like sometimes you see intramuscular metastasis, definitely picking up multiple findings or polytraumas. Sometimes, if you've got a very painful animal, it's very difficult to locate pain. I think we saw a few traumatic cases last time. So, yeah, there are instances when you end up doing quite a large area of a patient. But again, generally speaking, good question, good answer, rather than just kind of check for everything and hope for the best, really. So that would be my advice. Perfect. I think that's all we've got. So, in that case, I'll just go on to the last final bits of housekeeping, and I think we are sorted. So, finally, so we've got more case-based radiology webinars coming up over the next few weeks. So the next couple are going to be taken by a colleague, Olga, who is absolutely fantastic and has some lovely cases waiting. If you'd like to be in the know about these webinars or you'd like to view any of the webinars our team of radiologists has already done, we've got quite an extensive library at this point. Please scan the QR code. And if you'd like to learn more about the team, how we can support you and your team with our radiology service, please reach out. And one of our team will, or one of our client success team will get in contact. Perfect. And with that, thank you very much and have a lovely evening.